just to continue some of the key points that make the best examples for family care involve really allowing family members to care for the patient as they feel comfortable, and we as nurses have to see what that is, because some people are very good at providing care, and they don't get burned out, they don't overextend themselves. And then there are some family members who they've been in a caregiver role for so long they almost go through a depression at the point that they don't have that responsibility anymore. So it depends on what you assess in terms of how that is really affecting the family member. So we have to be their advocate as well and try to help them find ways to let go of those responsibilities if they're doing too much. And then also, for those that feel like they can do something and they should do something and it feels like a right of doing for someone as they are in the process of dying, then we want to support that and help them feel like they made a difference. Other things that we do with palliation type care to make the family more comfortable is, have wherever the patient is being cared for, if it's in the home or in the hospice home, try to make that room, that area, very comfortable with familiar things, family pictures. If young children aren't comfortable visiting or have illness and shouldn't visit, you can always have them send cards, notes, cute drawings, pictures, and have them call on the phone. Other folks who can't visit because they're, for whatever reason, or there's no time or they're too far away, it's important to encourage them to make phone calls or video chats. And even if the patient is at the point of being comatose, even to hold the phone to the patient's ear in a way where that person can say some nice final things that they want to say is very appropriate. Many families will find that recording stories from the person who's dying and as a group is very helpful as well, because it gives them a memory that may become a family legacy to listen to, or if it's video recorded, watch in the future. So where you think about people not in hospital settings not really supporting people using video or recording people, in this circumstance it's often very appropriate and very therapeutic. So in terms of post-mortem care, I know you've seen procedures and dealt with that already. Each hospital may have a little different policy, so it's important to kind of know what that agency's policies are. Different states may have specific rulings, and even specific counties in a state may have specific rulings that require certain things be done at the time of death. And your agency policies are required to follow those rulings at the state and county level. You may come across a patient that might be considered what we call a medical examiner's case. And if that happens, then you're not allowed to remove lines or tubes. They may have some other things that they indicate to you on the phone that need to be done. Occasionally they'll ask that lab work and things be drawn, or they'll want to see copies of records or review information with you on the phone, trying to decide whether they're going to do an autopsy or a full, or send someone from their office over to conduct an investigation and do some things. So just for general thinking, medical examiners' cases are driven from when a death is considered suspicious. And so different state rules will outline that. And it'll have you should have a policy at any place you go to work that clearly outlines what that is. For example, somebody who has had surgery, who is dead within less than 24 hours of surgery, often you're going to call that a medical examiner's case, just because they've died in an agency at a very rapid period of time for something that we did with them. Other things that might require an ME case, which you don't always think about, but imagine you're taking care of a patient who's quadriplegic, and they had a motor vehicle accident 2 years ago, and it left them somewhat brain damaged, and now they're ventilator dependent, and they've had multiple infections and had all kind of system failures, and so now they're dying, and they die from an infection. Well, that's not, you would think in your mind that's not a medical examiner's case because they died of pneumonia or something. But in reality, the accident itself is what led to them having a condition with the poor lung situation. And so that is generally considered a medical examiner's case because they can probably tie those things back to the original injury. Anybody that's had an accident, has been attempted to be murdered, anything like that. And you would just have to refer to the specific agency and city and county or state rulings on that, depending on where you practice. But you don't want to find that out after the fact. That's one thing when someone passes away, you really want to go dig in there and make sure you're not missing anything related to that. So a few key concepts that are important related to this also is trying to understand ethical distress versus moral distress. Ethical distress occurs when an individual identifies an ethically inappropriate action and they feel that they should not take that action. Okay? So it's more or less you're put in a situation where you're being told you have to do a certain thing, but you don't think it's in the patient's best interest, for example, or maybe it's against your beliefs for some reason. And you don't feel like that you should have to take that action because of either of those. Moral distress is a little different, but it sounds kind of alike, but it's important to kind of know the differences between these. Moral distress occurs when an individual identifies that ethically appropriate action, there's nothing really wrong with it, but feels still that they are unable to take action to ensure the ethically appropriate action. So, and you'll see a lot in literature about moral courage of nurses, meaning that they should, when these kind of actions are there, but they just don't feel like they can participate in it, they really need to examine if this is the right place for them to work or what is influencing their not wanting to take action. And, we can always have problems in work environments that lead to this kind of moral distress. In the next couple slides, I won't read those to you, but make sure that you read and see that you can kind of understand the difference of how these examples show an ethical dilemma, where you're having to, you don't want to take an action because you don't feel it's the right action. And then in the second example, you feel distressed because you're having to fulfill something that is over and over again a problematic situation, and you don't feel like you have the ability to act, based on this. So when you get in situations where over and over and over again you just feel like you're losing control, you feel upset about situations, and that's going to happen in any industry where you have a lot of customer service, but just trying to make sure you kind of get an idea of that, because having these conditions with moral distress have consequences. Nurses can be very disengaged, they can get very angry, they can act out, they can feel completely powerless and just feel like they're a victim all the time, very dissatisfied with their workplace and get burnout and leave. And you don't really want that. We think about nurses cope best by talking to each other, and that's very true. And while that is the most important thing to do for moral distress, to talk with a nursing colleague that is going to be supportive and helpful and encouraging that things will get better, and let you vent your frustrations. Sometimes you can get into negative think where you're there to complain about what your situation is, and that snowballs into the next person's complaint about the subject. And if no action is taken to kind of resolve that, because no one's taking any action, then it can get more and more a negative situation. So talking with the colleague is the best method for self-care on this, but it has to be that you're going to a supportive person and not somebody that is going to take you down the negative hole worse, and then you leave feeling worse than you did when you went there. So make sure that you select those people wisely. Other ways, if you don't feel like you can talk up about something, you can always journal and reflect on what the situation is in writing. And that's a good thing to use with patients as well in their self-care if they feel like they're in a situation where they can't talk about it, the problem, because they may write it out, and then maybe gradually they'll allow the person that really needs to read that and get that sense of what's the issue in terms of their distress. You can see other things that really help: staying fit and having enough stress reduction type strategies and hobbies and distractions. Teams also have to look at how is the best way to support each other. So you will see some of these kind of interventions on the best nursing units when you interview. So if you're going to go work in a high stress environment, or whether that's ER, ICU, caring of patients that may have experienced a lot of trauma or death and dying, they often will do things like post-mortem care as a team, so nobody ever feels like they're exposed to that just all alone. They may take moments of silence in meetings and things just to honor. They might send bereavement cards to patients and families as a group when they have a death. They may set up serenity rooms on their unit where any staff member, family, any other member of another discipline even can go in the serenity room and just do some meditation or relaxation before they have to go on to the next difficult situation. Some agencies actually have psychosocial support response teams that will respond if there is a death that occurs that's really kind of emotionally trying or difficult. And then maintaining a memory board on the unit is also a way, besides the moment of silence, to kind of honor some of the patients that people maybe have gotten very attached to. This is an interesting quote. A normal human being does not want the kingdom of heaven. He wants life on earth to continue. So what you see many times with death and dying is patients have certain beliefs and things all the way up till they get closer to dying. Because even though we can say that everybody knows that we all die, most people don't spend a lot of time thinking about it until death really becomes pretty imminent. It is very common also for patients to experience spiritual distress when death is imminent. They may have had certain beliefs their whole life, and then because they're dying, suddenly they're questioning and they're having spiritual distress, and they just they can't come to grips with it. You may hear comments made that really give you that idea when you're caring for somebody that's going through that process. the best thing you can do is encourage them to really discuss their feelings and thoughts. Spend some concentrated